Welcome back to this next video in which we are discussing inflammatory bowel disease. Okay, so in this next video we're now going to start studying the drug treatment for inflammatory bowel disease. So the first thing to say about the drug treatment of inflammatory bowel disease is that it's the same for Crohn's disease and ulcerative colitis. The second thing to say about the drug treatment of inflammatory bowel disease is that we can split it into two different types of treatment, namely the acute treatment and the preventative treatment. And we are going to begin by having a look at the acute treatment for inflammatory bowel disease, and then we'll go on to discuss the preventative treatments. So, what do I even mean when I say acute treatments of inflammatory bowel disease? This is the treatment that someone will take when they are actually having a flare-up or a relapse of their inflammatory bowel disease. So when they've actually got the inflammation occurring within their intestines, that's when they'll take the acute treatment for inflammatory bowel disease. And the aim is to reduce that inflammation and get rid of the symptoms of the flare-up. And as soon as the flare-up's actually over, you can then stop taking the acute treatment for inflammatory bowel disease. So it's the treatment that you take only when you're having a relapse to try and get rid of the relapse. In contrast, the preventative treatment you take all the time, even when you're in remission, and it's to try and prevent you having relapses, hence it's called the preventative treatment. So let's start off with the acute treatment for an inflammatory bowel disease flare-up. So the aim of the drugs that we're going to give as acute treatments for inflammatory bowel disease flare-ups is to have an anti-inflammatory effect. We want to get rid of the inflammation, and drugs that reduce inflammation are called anti-inflammatory drugs. So, there are two major classes of drugs that we're going to use for their anti-inflammatory effects as acute treatments for a flare-up of inflammatory bowel disease. And the first of these is oral glucocorticoids, which you can also refer to, and indeed are commonly referred to, as oral corticosteroids. However, their proper name is oral glucocorticoids. Okay, so the boring bit firstly, let me just list off some examples of oral glucocorticoids, and there are quite a few of these. So probably one of the most famous, one of the most commonly used, is a drug called prednisone. Now, prednisone is actually a prodrug that is converted in the liver to its active drug, which is prednisolone. However, you can actually give the active drug straight away, so you don't have to give prednisone, you can give prednisolone, which is why I put both of them there. Prednisolone is just the active form of prednisone, but you can just give this one straight away. There is then a modified form of prednisolone, which is called methylprednisolone, and this one can be given as well and will also have glucocorticoid effect. More oral glucocorticoids. Another very important one is hydrocortisone. And then two more important ones, which I'll put over here. There is dexamethasone. And they're all going to have the same effect, all of these oral glucocorticoids, and triamcinolone. And these drugs are all given orally, as is implied by the name. So triamcinolone. So, here are 6 examples of oral glucocorticoids. Prednisone, which is a prodrug for prednisolone. Methylprednisolone, which is a modified version of prednisolone. Hydrocortisone, dexamethasone, and triamcinolone. So these are all oral drugs that are going to have very profound anti-inflammatory effects and which will reduce the inflammation occurring within the intestine during an inflammatory bowel disease flare-up. So, how do the oral glucocorticoids actually work? Well, they hijack a system that is in place for the endogenous hormone cortisol. So cortisol is an endogenous hormone that is secreted into the blood by the adrenal glands and which can have a very powerful anti-inflammatory effect. And all of these drugs are going to do the same thing as cortisol would do. So through these drugs, we are just hijacking a natural pathway that is present within the body, a natural system within the body for reducing down inflammation that is occurring in tissues within the body. And actually, hydrocortisone is actually the same molecule as cortisol. When we give it as a drug, we call it a different name, but it is the same molecule. Hydrocortisone is cortisol. Okay, so let's just go over briefly the glucocorticoid pathway then. How do these drugs actually work? So when you give one of these drugs, or indeed if you gave cortisol, which we know is hydrocortisone, what will happen is the drug will go into the cells all over the body. So they can diffuse through cell membranes. So they can go through the cell membrane into the cytoplasm of cells. And in the cytoplasm of cells, there is a receptor that they can bind to. And this receptor is known as the glucocorticoid receptor. So let me just draw this here. So for short, I'll abbreviate the glucocorticoid receptor down to the GR. So here is the glucocorticoid receptor, and this is usually present within the cytoplasm of cells. However, it's normally not doing anything, and the reason it's not doing anything is that it has an inactivating protein bound to it, which I'm drawing on here, HSP90, and this stands for heat shock protein 90, and the 90 is just to do with how much the protein actually weighs, 90 kilodaltons. So, there is this protein in the cytoplasm of all cells around the body called the glucocorticoid receptor, the GR for short, which is usually sitting in the cytoplasm inactive and which is bound to the heat shock protein 90, which keeps it inactive. When a glucocorticoid, any one of these, the endogenous one being cortisol, comes into the cytoplasm of the cell through the cell membrane, it combines to the glucocorticoid receptor and causes the dissociation of the heat shock protein 90 from the glucocorticoid receptor. So let me just draw this here. So here is our glucocorticoid receptor now, and now it's going to have the drug bound instead, and I'll draw the drug in red here. So I'll just put a capital G here for glucocorticoid. So this is our glucocorticoid bound to the glucocorticoid receptor now. So what happens now? Now that the glucocorticoid receptor no longer has the heat shock protein 90 holding it back, it can now go into the nucleus of the cell. So it'll go into the nucleus, and then what will happen is it will dimerize with other glucocorticoid receptors that have entered the nucleus. So let me just draw this here. So here's one glucocorticoid receptor and here's another glucocorticoid receptor, and they've dimerized together, and both of them will have to have a glucocorticoid bound to them. So here's that one's glucocorticoid and here's this one's glucocorticoid. So they dimerize once they're in the nucleus. I'll just put this alongside here. So once they're in the nucleus, dimerization occurs, and then what does this complex of two glucocorticoid receptors with glucocorticoid molecules bound to them actually do? Well, it acts as a transcription factor inside the nucleus of all the cells around the body. It changes gene expression. So it's going to change gene expression. So these are very, very, very powerful drugs. Indeed, cortisol is a very, very powerful hormone. It goes into loads of cells all over the body and changes gene expression within those cells. And it has hugely wide effects. So it has a variety of effects all over the body. However, the effect that we are interested in is the anti-inflammatory effect that these glucocorticoids can have. So coming back up to our pathogenesis here, the glucocorticoids can go into sentinel cells all over the body, but in particular we're interested in the sentinel cells within the lamina propria of the intestines. They will go into those sentinel cells, change gene expression within those sentinel cells, and they block the production of inflammatory mediators by those sentinel cells. So they block the production of interleukin-1, they block the production of TNF-alpha, they block the production of other inflammatory mediators as well. So all of the inflammatory mediators that were being produced by these sentinel cells are now no longer going to be produced in anywhere near as high quantities. And of course, these inflammatory mediators are the things that cause the inflammation. They have the effect on the microvasculature in the case of interleukin-1 and TNF-alpha to actually cause the exudate formation and bring in white blood cells into the lamina propria. Also, other inflammatory mediators are responsible for the other affects the other symptoms that you get with a flare-up of the inflammatory bowel disease. So prostaglandin E2 is responsible for the pain. Interleukin 6 is very important for constitutional symptoms, and platelet activating factor is very important for the diarrhea. So by blocking the production of these inflammatory mediators, we're going to tone down all of the symptoms of the flare-up of the inflammatory bowel disease. And so to repeat that again, glucocorticoids, very powerful drugs, go into all the cells in the body, change gene expression. But the reason that we're interested in that is that when they go into sentinel cells all over the body, they're going to stop the production of inflammatory mediators. And when this occurs in the intestine, that's going to mean that we're going to get reduction in the symptoms of the inflammatory bowel disease flare-up. Which is how they're going to be successful in treating an inflammatory bowel disease flare-up, and why they're a successful acute treatment for inflammatory bowel disease. So they have a profound anti-inflammatory effect. They've reduced the inflammatory response by reducing the production of inflammatory mediators. Now, these drugs can only really be given acutely. You can't give them long-term because, as well as having anti-inflammatory effects by going into sentinel cells, they have loads of other effects all over the body in other tissues, and some of these other effects cause problems, basically. So, for instance, if you use glucocorticoids for a long time, you get very thin skin, you get very thin bones, you get osteoporosis, you start to put on weight, particularly central weight, so you end up with a big belly and a round face. You end up with high blood pressure. They can give you diabetes, or they increase your risk of developing type 2 diabetes. So taking glucocorticoids long term is not ideal at all, which is why these drugs are really advised to only be used acutely. So they're used as an acute management for a flare-up in inflammatory bowel disease, but they shouldn't be given long term. Now, there's a special name for what they can cause if you give them long term for too long. They cause what's called iatrogenic Cushing's syndrome. So Cushing's syndrome is this collection of symptoms that people get when they've got far too much cortisol within their blood, or some other glucocorticoid, one of these exogenous glucocorticoids here within their blood. It's the things like having thin skin, having osteoporosis, having a round face that's called the moon face, having a big belly, being hypertensive, developing type 2 diabetes, developing other components of the metabolic syndrome. That's what we call Cushing's syndrome. Iatrogenic means it's caused by doctors, it's caused by medical interference. So iatrogenic Cushing's syndrome is where we've caused Cushing's syndrome by giving people exogenous glucocorticoids in high doses for a long period of time. So this is what we're trying to avoid. We don't want to give these drugs long term because they lead to iatrogenic Cushing's syndrome if they're given long term. So those ideally should only be used acutely, but they are incredibly effective. It's sad basically that they are incredibly effective, but they have these side effects if they're given long term. So they can only be given really for acute management, or are advised to only be given for acute management. Okay, so the next category of acute drugs that are given for a flare-up of inflammatory bowel disease are what we call the Amino salicylates. Okay, so again, the boring bit, let me just list out the names, and there's less names this time, just 2 drugs this time. So there is a drug called sulfasalazine, and then there is another drug called salazine. And in fact, sulfasalazine is the prodrug for salazine. So salazine is the actual active drug of sulfasalazine. When you take sulfasalazine and it's taken orally, it is actually converted by the enterocytes of the small intestine into salazine. So salazine can be taken directly as the actual active drug, or you can give sulfasalazine, which is the prodrug for salazine. Either way, you end up with salazine in the intestine. Now, salazine also has another name, which I'm just going to give you, which is 5-amino salicylic acid, which for short is abbreviated down to 5-ASA. And this is just spelt very similar to this. So take off the 8 and put ic there, and you've got amino salicylic. and then A is for acid, so 5-amino-salicylic acid, and that is obviously just the chemical name of what mesalazine's structure actually is. Okay, so these two drugs, the aminosalicylates, they are anti-inflammatory drugs as well that are very effective in inflammatory bowel disease. How do they work? We don't really understand their mechanism at all. What we do know is that they somehow stop the release of the inflammatory mediators as well. This is the major way to have an anti-inflammatory effect, to stop the production of these inflammatory mediators. We saw that that's what the oral glucocorticoids are going to do, and that's why they're so effective. The aminosalicylates do the same thing, but the mechanism isn't understood. So somehow mesalazine blocks the production of, or gets rid of, we don't know whether it blocks the production or whether it gets rid of them, it inactivates them, but somehow it takes away the effect of the inflammatory mediators, and as soon as you kill that, then the inflammation will go down and all of the symptoms of the flare-up of the inflammatory bowel disease will go down. So that's the second class of drugs then that are used in the acute management of an inflammatory bowel disease flare-up. Okay, so now we're moving on to the second major category of drugs used to treat inflammatory bowel disease, which are the preventative medications. So these are drugs that you take all the time to prevent a relapse in the inflammatory bowel disease. So even if you've been free of a flare-up of the inflammatory bowel disease for months, you still take this medication to prevent a relapse from occurring. Okay, so these reduce the chance that a relapse is going to occur. Now, preventative medications then, you can actually take aminosalicylates long-term to try and prevent a relapse of inflammatory bowel disease. So I actually put them as number 1 up here. However, in many people, these are not good enough to actually completely stop relapses. But in some people, they are good enough, and they are more tolerable than oral glucocorticoids. Oral glucocorticoids would be fantastic. If we could give people oral glucocorticoids long-term without giving them iatrogenic Cushing syndrome, that would fantastically stop relapses in inflammatory bowel disease, because you'd have a chronic anti-inflammatory state, and even if the adaptive immune system is trying to cause inflammation, with those oral glucocorticoids present, you're not going to get inflammation occurring. However, we can't give those long-term because of the iatrogenic Cushing syndrome, or we hate giving them long-term because of iatrogenic Cushing syndrome. Aminosalicylates are much more tolerable. They don't cause Cushing syndrome, and they do have an anti-inflammatory effect, and therefore stopping the inflammatory mediators will stop relapses in inflammatory bowel disease. However, generally they're not strong enough on their own to completely stop relapses in inflammatory bowel disease. But if they are in an individual, then bravo, they can be used. Now let me talk about other preventative medications. So other preventative medications that can be used are drugs that are in the class of immunosuppressants. So an important thing to understand is what is the difference between an anti-inflammatory drug and an immunosuppressant drug. An anti-inflammatory drug gets rid of the inflammatory response. It turns the innate immune system off. Whereas an immunosuppressant drug, it turns off the adaptive immune response. These are drugs that stop the adaptive immune response. So that's the difference between anti-inflammatory and immunosuppressant. Oral glucocorticoids are actually both anti-inflammatories and immunosuppressants. However, because we don't want to use them long-term, we're not actually using them for their immunosuppressant effect, we use them for their anti-inflammatory effect. I'm now going to tell you some other drugs that have less side effects than long-term oral glucocorticoids, which have an immunosuppressant effect. So, number 1 on this list is a drug called methotrexate, which is also used as an anti-cancer drug. And in fact, I should say a lot of these drugs can be used as anti-cancer drugs because the way that they work is by stopping cell division. So we can contrast the mechanisms of immunosuppressants to anti-inflammatories. Immunosuppressants, remember, they stopped the inflammatory mediators. Got that the wrong way around. Anti-inflammatories stopped the inflammatory mediators. Immunosuppressants are going to work by stopping cell division. And this is why they can also be used to treat cancer, because cancer is, of course, cells dividing too rapidly. So why is stopping cell division going to have a suppressive effect on the adaptive immune system? Well, it's because of this. To keep the adaptive immune system activated, you're continually having to reactivate CD4 positive T cells, namely the memory CD4 positive T cells, and they then have to divide to produce loads of progeny, which can then differentiate into more memory CD4 positive T cells, and then effector helper T cells. Because remember, effector helper T cells are short-lived, so if you want to maintain an adaptive immune response, you have to continually be producing more of them. So this division has to occur, basically, and if we give one of these drugs that stops cell division, it blocks that, and therefore the cell can't divide, and therefore you don't get the production of more effector helper T cells, and therefore once all of the effector helper T cells that you've got at the moment have died, then you won't have any more, and hopefully that then is going to stop the thing that is going wrong in inflammatory bowel disease. It's, if you like, a more original, or that's the wrong word, a more going back to what the original problem is solution. The anti-inflammatories, they were dealing with the problem quite far down the pathogenesis line. They were stopping the inflammatory mediator production, whereas the immunosuppressants are going back to the fundamental problem, which is with the adaptive immune response. Okay, so I hope you understand why stopping cell division is going to have an immunosuppressant effect. Let's now study these drugs that do stop cell division. So methotrexate is a very famous example, very important example. This is a drug that inhibits an enzyme called the dihydrofolate reductase enzyme, for short the DHFR enzyme. So this is the dihydrofolate, and then the R is for reductase enzyme. So just drawing a little picture here, the classic little picture of an enzyme here. This can represent dihydrofolate reductase. So what does dihydrofolate reductase normally do? It's involved in converting a molecule called dihydrofolate, which I'll abbreviate down to DHF, into tetrahydrofolate, which is THF. So just replace the di here with tetra, and you would then have tetrahydrofolate. So this enzyme, dihydrofolate reductase, it's found in all cells in the body, and it converts a molecule called dihydrofolate into a molecule called tetrahydrofolate. And if you don't know anything about dihydrofolate or tetrahydrofolate, don't worry. All you need to know is that tetrahydrofolate is extremely important for building all sorts of molecules in biology. So in order to build lots of very important molecules within cells, you need tetrahydrofolate, and therefore you need functional dihydrofolate reductase. Now, in particular important to us is the fact that tetrahydrofolate is needed for producing the organic bases of DNA. So thymine, adenine, cytosine, guanine, all of the organic bases of DNA that are used, to code the genetic information. To create those molecules, and cells do need to create those molecules, you need tetrahydrofolate. Now, when a cell is going to divide, you're going to be producing loads of new DNA. You're going to be copying all the DNA within that cell in order for that cell to divide, and therefore you're going to need lots of organic bases. Therefore, you're going to have to synthesize more organic bases. And if you don't have enough tetrahydrofolate, you're not going to be able to synthesize enough organic bases, and therefore you're not going to be able to divide. So to summarize this, methotrexate is a drug that is given as an immunosuppressant and also sometimes as an anti-cancer drug. And it goes inside the cells within your body and inhibits an enzyme called dihydrofolate reductase. Inhibiting this enzyme stops the production of tetrahydrofolate from dihydrofolate. If you don't have enough tetrahydrofolate, you can't synthesize more organic bases. This molecule is used to synthesize loads of different molecules in biology. In particular, it's used to synthesize the organic bases. If you don't have enough of this, you can't synthesize enough organic bases, and therefore you can't divide. So we end up blocking cell division. So organic bases are needed for cell division. Therefore, if you don't have enough of them, you can't divide. So that is how methotrexate is going to end up stopping cell division, and then, of course, by stopping cell division, it will have an immunosuppressant effect. No more effector helper T cells, no more inflammatory bowel disease is the idea anyway. Now, another great class of immunosuppressants that is used for the preventative treatment of inflammatory bowel disease are what are called the purine analogues. So there are 3 different drugs under this category, so let me list them out. So the first one, which is a very important drug, is a drug called azathioprine. The second one is the actual active version of this, which is a drug called 6-mercaptopurine. And for short, we can abbreviate 6-mercaptopurine down to 6-MP. And then the final one is a drug called 6-thioguanine, which for short can be abbreviated down to 6-TG. So these drugs are all in this class of purine analogues, and they're used as immunosuppressants and also occasionally to treat cancer. So azathioprine is a prodrug that is converted to 6-mercaptopurine. This is the active version of azathioprine. But you can just give 6-mercaptopurine straight away. 6-thioguanine is another example of a purine analogue. So what do these drugs do? Well, the name here that I put here gives them away. These are analogues of the purine organic bases. And remember, the purine organic bases are adenine and guanine. So we split the organic bases into 2 separate classes. The purine organic bases, which have purine rings within their structure. So this is a chemical division, which are adenine and guanine. So A and G. I'll just put that here. So A and G organic bases are purines, and then the pyrimidines, which have pyrimidine rings within their structure, and that's thymine and cytosine. So these drugs, azathioprine and its active version 6-mercaptopurine and 6-thioguanine, these are analogues of the purines. They have very similar structures to adenine and guanine, and they are actually capable of inhibiting the production of purines. So they go inside cells and they then end up binding to loads of the enzymes that are important in producing purines, and therefore they inhibit purine synthesis. So here we go. They inhibit purine synthesis. So again, these are going to work by stopping organic base synthesis. So 6-mercaptopurine and 6-thioguanine, and remember 6-mercaptopurine is the active drug of azathioprine. They will go into cells, inhibit loads of enzymes involved in the synthesis of purines, and thereby stop the production of purines. And if you don't have enough purines, then of course you don't have enough organic bases, and if you don't have enough organic bases, you can't divide because you can't copy your DNA, so they will end up stopping cell division, and that will produce an immunosuppressant effect. Okay, so those are the different immunosuppressants that can be used as preventative treatments for inflammatory bowel disease. We have methotrexate, which is a dihydrofolate reductase inhibitor, and then we have these 3 examples of purine analogues, azathioprine, which is a prodrug for 6-mercaptopurine, and then 6-thioguanine. And these are all going to work overall by stopping the production of enough organic bases within cells, and thereby stopping cell division, and thereby stopping the production of effector helper T cells. Okay, right. A final class then of preventative medications that can be used in inflammatory bowel disease are what we call the anti-TNF alpha drugs. So I'll put these here. So the name, again, gives away what these drugs are going to do. Anti-tumor necrosis factor alpha drugs. So these are reasonably new drugs. They are monoclonal antibodies that are directed against tumor necrosis factor alpha. So very clever biomedical scientists have engineered antibodies, which are molecules that plasma cells, which are the effector B cells, can produce to as part of the adaptive immune response. And of course, we haven't looked at B cells in this video, but from background knowledge of immunology, I'm sure you are aware that antibodies are produced by effector B cells and are an incredibly powerful part of the adaptive immune response when they're actually used. Thankfully, we don't think they actually are used in inflammatory bowel disease. It's just the CD4 positive T cells that go wrong. But very clever biomedical scientists have taken antibody molecules and engineered them so that they are actually capable of binding to tumor necrosis factor alpha. So we've produced monoclonal antibodies, which means that it's a single type of antibody with a specific binding site that can bind to tumor necrosis factor alpha. And we can give these drugs and they will mop up tumor necrosis factor alpha. So we've produced different versions of this. They're all monoclonal antibodies that can bind to tumor necrosis factor alpha, but different people have produced slightly different variants. You can produce more than one antibody that's capable of binding to TNF alpha. So here are some names of these drugs. So a very important one is infliximab. Another very important one is a drug called adalimumab. So whenever you see MAB on the end of a drug, it means monoclonal, and then the AB is for antibody. And then another one, quite new one, is certolizumab pegol. So certolizumab pegol. So as I say, these are all monoclonal antibodies that can bind to tumor necrosis factor alpha and which can be given to people and which are used preventatively to prevent inflammation from occurring and therefore prevent relapses in inflammatory bowel disease. And the way that these will work is that they will mop up tumor necrosis factor alpha. So if you were trying to have a relapse of inflammatory bowel disease, if the adaptive immune response was trying to initiate an inflammatory response, then of course the sentinel cells will be releasing the inflammatory mediators, and these drugs will mop up all the tumor necrosis factor alpha, and without that, you're going to get a hugely reduced inflammation, and therefore you're hugely going to tone down relapses in the inflammatory bowel disease. So these are incredibly effective drugs at reducing the relapses of inflammatory bowel disease. So the great thing about these drugs is that they can be given very rarely. You see, because they are monoclonal antibodies, they stay in the bloodstream for a long time, because indeed when we create antibodies endogenously from our effector B cells, our plasma cells, those antibodies circulate for weeks and weeks and weeks before they're finally removed. So that's the brilliant thing about these drugs. Because they're monoclonal antibodies, they will stay in the blood for a long time, and therefore they don't have to be given that regularly. Indeed, infliximab is given every 4 weeks, and it's usually given by intravenous injection. So often people go into hospital to have their every 4 weeks intravenous injection of infliximab. Adalimumab and certolizumab pegol are given slightly more frequently. They're given every 2 weeks, and they are given by subcutaneous injection. So this is the abbreviation for subcutaneous injection. So that's an injection just underneath the skin. And because giving yourself a subcutaneous injection is far easier than giving yourself an intravenous injection, people can often give these drugs themselves. But again, this is fantastic that you only have to give it every 2 weeks. So it's not a drug that you have to take every day. So it's quite an easy drug as far as taking it is actually concerned, because you can just take it rather infrequently. Okay, so to summarize these anti-tumor necrosis factor alpha drugs, they're very new drugs, but they are used and they are incredibly effective at preventing relapses of inflammatory bowel disease. They are monoclonal antibodies that clever biomedical scientists have created that are capable of binding to tumor necrosis factor alpha and mopping it up, and therefore reduce inflammation. So again, they are producing a chronic anti-inflammatory state. The wonderful thing about them is that they don't have to be given that often, because like endogenous antibodies, they will stay in the bloodstream for a long time. So infliximab only has to be given every 4 weeks, and it's given by intravenous injection. Adalimumab and certolizumab pegol are given every 2 weeks, and they're given by subcutaneous injection, which means that it's easier to give, and people can often give them themselves because they just have to inject it underneath their skin rather than putting it into a vein. Okay, so that finishes our discussion then of the preventative treatments of inflammatory bowel disease. So you have the aminosalicylates, which are anti-inflammatories, the anti-TNF alpha drugs, which are anti-inflammatories, and then the immunosuppressants, which are, of course, immunosuppressants. So, with that then, we've finished the entire video on inflammatory bowel disease. Thank you for watching it. I hope that you have learned something from it and enjoyed it.